Some journeys aren't defined by a destination, but by their transformation. From passionate beginnings to defining milestones, the Pakistan Cardiac Super League became the heartbeat of academic excellence. Two pioneers joined forces once again to ignite the spirit of learning and leadership. What began as a challenge became a movement. In every round, a new hero emerged. In every team, a story was written. Now, the legacy continues as 16 elite teams step into the arena to prove their strength, their skill, and their synergy. Team L&H Pelicans, Team SGTH Tigers, Team BVH Cardinals, Team FIC Fighters, Team SICVD Thunders, Team AFIC Lions, Team PIC Hawks, Team Dow Dolphins, Team NICVD Kings, Team RIC Dreadnoughts, Team Looms Falcons, Team MIC Panthers, Team AQH Stars, Team BMC Strikers, Team HMC Stallions, Team PIC Warriors. Guided by the visionary stakeholders of the Pakistan Cardiac Society, steered by the Governing Council, the backbone of PCSL. Judged with fairness and integrity by our panel of expert umpires, and held together by the voice of reason and brilliance, Dr. Hamza Gowri, our moderator, whose pivotal presence made this league a resounding success. Glory goes beyond borders. The winning team will earn a prestigious opportunity to participate in an international cardiology event. Mark your calendars, the battle for brilliance begins August 9th. Pakistan Cardiac Super League, Season 3, the ultimate test of knowledge. Powered by Wilson's Pharmaceuticals.
Bismillahirrahmanirrahim. Assalamu alaikum everyone. I am Syed Hamza Hussain and I am super excited to welcome you once again for the fourth quarterfinal match, which is going to be played between NICVD Kings and PIC Hawks from Lahore. And just to update you, the winner of today's match will be booking their seat for the hot second semi-final match, which will be played against AQH Stars.
So we can't hear you,
and
Hamza.
This event, as always, is brought to you by Pakistan Cardiac Society in collaboration with Wilson's Pharmaceuticals. Moving forward, I would like to introduce the umpires and esteemed council members of Pakistan Cardiac Super League. We have with us the match umpire, Professor Mohammad Ishaq Saab, Professor Abdul Hamid Siddiqui Saab, and from the council members, we have with us Professor Fawad Farooq, Professor Amber Ashwar Saiba, and more panelists will be introduced during the course of the match. And last but not the least, I would now introduce the moderator of Pakistan Cardiac Super League. You all are familiar with the name Dr. Hamza Ghori. Dr. Hamza Ghori is serving as Assistant Professor of Cardiology at RIC and is also a stroke interventionist. And I would now request Dr. Hamza Ghori Saab to please start the formal proceeding of today's match. So over to Dr. Hamza Ghori Saab.
Thank you very much, Hamza. So we are here back with this outstanding program, and we all know what we are talking about. So it is the third season of Pakistan Cardiac Super League, which is brought to you in collaboration with Wilson Pharmaceutical and Pakistan Cardiac Society. And we know that it has been outstanding this year. We've had some extremely tough matches. The last match was no less. So again, here today, we are with this fourth quarterfinal, and it's going to be an extremely important game. Whosoever wins goes to the semis, and there is one team waiting for all of you. So for today's match and this fourth and the last quarterfinal, we have NICVD Kings versus PIC Hawks. And we hope that the two teams are geared up and they are ready to lock the horns. But before we move on, the important things first. So we have our panel of experts and umpires. I'll start with Professor Mohammad Ishaq Saab. He's our number one umpire, as I always say, because he's always there and he's always there to guide everyone. We also have our second umpire, that is Professor Abdul Hamid Siddiqui Saab, and he's going to be there with us throughout to guide wherever needed. We also have our faculty member, Professor Dr. Amber Ashraf. Ma'am, you've been instrumental with this show. You're always there, and your presence actually makes a lot of difference. And you bring that woman power with you. And that's, I think, is extremely important for all the girls who are out there and they are rooting to become cardiologists and interventionists, inshallah. And we'll have the introductions as more dignitaries hopefully will be joining us. So today, it's an important match, the quarterfinal, the last one, and the two teams. So I'm just going to turn towards one of the teams and I'll ask the captain to have the introductions, please. So we move towards PIC Hawks. Can we have them on the screen, please?
Assalamu alaikum. It's a PIC Hawks captain, Dr. Arham, final year resident, PIC Punjab Institute of Cardiology, Lahore. And with me is the Dr. Kashif, third year resident, Punjab Institute of Cardiology, Dr. Shahid, final year resident, Punjab Institute of Cardiology, and Dr. Azaz, third year resident, Punjab Institute of Cardiology.
All right. So I hope you guys are geared up and
yes,
prepared.
Sir. Yes, sir.
Okay. Best of luck to you.
Thank you, sir.
So we have NICVD Kings with us. Kings, introductions, please.
Assalamu alaikum. I'm Dr. Farhan, captain of NICVD Kings, and I have Dr. Osama, Dr. Neelam, and Dr. Sumera.
Are you geared up as well?
Yes.
Looking good? Confident?
Exactly.
That's good to know, and best of luck to both the teams for today's match.
Thank you, sir.
All right, then. So I'll say the weather report looks pretty good, pretty chilly out there. But at the same time, the pitch looks, it's a bit grassy pitch, I tell you. And there's some bounce as well. So you've got to be, and yes, we've got Professor Hafizullah, sir. It's great to have you. Yes, the fourth quarterfinal awaits.
Thank you. Thank you. It's a pleasure to be with you, and so you make the match look very interesting, and you put all the excitement into the hearts and souls of people. Excellent job. Wonderful.
Thank you very much, sir. I think it's our residents who really go for it, and they are so well prepared this time around. You know, it makes me realize that they're going to give a tough time to all the examiners of FCPS, I tell you, or their MDs. So
let's hope so. Let's hope so.
That's good. That's
Examiners
good.
only get happy if the answers are right. They don't give tough time to the examiners. The examiners become very happy when you get proper, correct answers. And you are very depressed if the answers are incorrect.
Absolutely, sir. I think you've explained the whole thing to them, and I think this is what it is. The examiners, they want the students to pass, and they want them to become brilliant doctors and cardiologists, especially in our field. So with this,
I fully endorsed what sir is saying, and that really give us energy where we all are today because of our teachers, mentors like Professor Hafizullah Saab, Ishaq Saab, and rest of that. And that's totally, I endorse it. Stay blessed.
Very right, ma'am. Actually, I think the mentors, they see themselves in their own students and their own reflection. So it's always so good to see that. So with this, we know that it's going to be an interesting game, and best of luck again. So I'm going to move to the electronic coin toss. Can we have it on the screen, please? Or do I have to pin it? Yes. All right. So now I have it on my screen as well. And I'll ask randomly one of the teams. So NICVD Kings, I see you there first. So what do you think? What do you want? Heads or tails?
Heads.
NICVD Kings, they say heads, so roll the coin. Let's see what happens. And it's heads. Wow. So NICVD Kings, so the first luck going in your favor, you win the toss. And again, as you know, I'll have two questions for you. The first one, you want to throw the questions or you want to take the questions?
We want to throw the questions.
You want to throw the questions. And the second part of the series now, question series, is case A or case B. Which one do you want?
We want case A.
Okay, so you have selected case A. Okay then, so the news from the center is NICVD Kings have won the toss and they want to throw the questions, and the case series is case A that they have selected. All right, so with this, I'll seek permission from the council to start the first inning, sir and ma'am.
Go ahead. We are waiting for a wonderful match. Go ahead.
Thank you very much, ma'am. And with this, let the games begin. And can we have case A, scenario A on the screen, please? Kings, are you ready to read it?
Yes, but just a half screen.
Yes, we can't see it properly. You'll have to adjust. They're right. Technical team, you'll have to bring the question on the screen.
नहीं आ रही.
Hold on, I think the team is on it.
No.
Technical team. Okay, so
font size कम कर दें. Font size अपनी
Still
तरफ
not.
से लिखा
So
होगा.
they're trying to fit it into the screen. Let's see.
It's okay now, sir?
No, we still can't see it completely. Can you see it completely?
No.
Teams?
No,
No, they can't, Hamza.
No.
Nobody can see it properly. I think you'll have to bring that particular screen on. Why can't we have that one on the screen?
इसको full कर दें. Sir, it's complete now.
No,
No,
but
no, no.
we only see the side windows, Hamza.
Yeah. Yeah.
We are
it's
seeing
half and
multiple
half.
windows. That main screen is not coming separately like it used to do previously or on a weekly basis. Today there is something different about it. वो मेन स्क्रीन आपकी अलग से नहीं आ रही है. आपको ये आई थिंक मल्टीपल स्क्रीन्स हटानी पड़ेंगी. You'll have to take them out. Now it's only me on the screen.
You are more than enough.
Thank you very much, sir. But we still need the question to move on. Oh.
यार ये व्यू आ रहा है लेकिन.
इसमें कुछ सिलेक्शन हुई है बैकएंड से, मैं वो देखूं क्या ये तो नहीं है. तो ऑटो फ्रेमिंग लगी है ऐसा है. बट ठीक है बना वो बैकएंड से ना.
Okay, we do have it on the screen now. Can you see it?
Yes.
सर ये काफी सा छोटा नजर आ रहा है सर. रीडेबल नहीं है ये.
Hamza, can we do something about it? Can they see the question? Why can't we remove the two windows just for now and just have the question? Rather the scenario on the screen.
Maybe that you can read the scenario yourself, and that should be sufficient. And then we can project the questions on the screen again.
Right, sir. I'm also trying to get to it. Okay. Okay, so maybe I think, can you read it now?
Yes.
Teams. Okay, then let's just start the case scenario then. I think both the teams can see it. We can all see it.
Yes, a 48-year-old man with hypertrophic cardiomyopathy present with exertional chest pain, near syncope on climbing stairs, and occasional nocturnal palpitations. He has no history of hypertension. His father died suddenly during football match at 36 years of age, and then there's no post-mortem was done. Medication including metoprolol 100 mg per day, atorvastatin 20 mg per day. On examination, heart rate is 64 beats per minute, blood pressure is 112/68. High systolic murmur at left lower external border, which increases with Valsalva, and there's no peripheral edema. ECG shows LVH with deep T wave inversion in inferior lateral leads. In transthoracic echocardiogram, asymmetric septal hypertrophy, maximum wall thickness of 21 millimeters. And resting LVOT gradient 25 mmg to 72 mmg with Valsalva. And systolic entry motion of with mild to moderate MR. And small LV cavity, LVF 70%, no mid-ventricular gradient. CMR shows basal septal hypertrophy, small apical aneurysm of 15 mm with thin wall dyskinetic segment. Patchy mid-wall and rim late gadolinium enhancement, totaling 11% of LV mass, including apical rim. And Holter show 48-hour Holter shows severe runs of non-sustained VT, longest of 16 beats at 145 beats per minute. There's no FF. He's in NYHA class 2 to 3 despite beta blockers. He asked about ICD, mevacaptan assay, and surgical myomectomy, and his long-term heart failure risk.
All right, PIC Hawks, I think you'll definitely need more than a couple of seconds to go through it. Just let me know when you're ready, but you can always see this scenario whenever you want during the course of this innings while you're answering your questions.
Sir, we are ready with the question, but please increase the size of screen, sir. It's not quite clearly visible.
Okay, technical team, please help them with this. I think they should have an alternate way. Maybe you can have your WhatsApp or any other screen that you can provide them with. So with this, I think let's move with the first question of this first innings. Can we have it on the screen, please?
Hamid ko call kare.
Can we have the first question?
Question number 1 lagay.
Read the question, please.
Which single feature in this patient is the strongest major indication for primary prevention ICD, independent of risk calculators? A is non-sustained VT on Holter. B is family history of sudden cardiac death at 36 years. C is exercise-provoked LVOT gradient of 72 millimeter of mercury, and LV of 70%. And E is presence of an apical aneurysm.
All right, so we will have 60 seconds to answer this question. Please start the timer. And I'll request everyone else to keep their mics on mute. Hamza, you too, because we don't want any crosstalk here. Approaching 25 seconds.
So it's beta family history of sudden cardiac death at 36 years of age.
B beta. Okay, so you want me to lock this one?
Yes.
You're starting with a cover drive. Should I lock it?
Yes.
Okay, lock B beta. Oh, and that's nicked into the slips. My goodness. That's the first mistake on the first delivery. The first question. Okay. But never mind. You still have 9 more questions. And the question number 2 is on the screen now.
What is the most appropriate antithrombotic strategy for this patient's apical aneurysm, assuming no prior embolic event and sinus rhythm? A is no antithrombic therapy. B is aspirin alone. C, warfarin with target INR of 2.5 to 3.5, and direct oral anticoagulation at full AF stroke prevention dose. And E is dual antiplatelet therapy.
And you have 60 seconds to answer this. Start the timer, please. Answering team, please unmute yourselves. We want to hear the discussion. And PIC Hawks are pretty animated as always. They're discussing, and that's what we want to see.
Assuming no pure embolic event and sinus rhythm. चले कोई रिस्पेक्टर नहीं है अपने एंटी-थ्रोम्बोटिक साइनस रhythm ठीक it's delta DOAC at full AF stroke prevention dose.
D delta. Should I lock it?
Yes.
Are you sure?
Yes. No.
Okay, so lock D delta and let's see. And this one is the correct one. Great answer. So you're on the board. Brilliant. Well done. Well done. And that's what we wanted to see. So good stroke, straight drive. I think it was a straight drive over the bowler's head and a wonderful 6. Well thought out and well played. All right. Bring question number 3 on the screen.
Which finding most strongly argues against alcohol septal ablation at first line septal reduction therapy here? Age 48 years, LVOT gradient only with provocation. C is thin wall apical aneurysm, and D is resting gradient less than 30 mm mercury and late gadolinium enhancement of 11%.
Start the timer.
60
seconds. Start the timer, please. 60 seconds. Someone has to start the timer. Yes.
Less than 30. इसमें ये 30 से कम है तो इसमें कोई नहीं कर उसमें फर्स्ट नहीं है उसमें मतलब उसमें सर्जिकल या कोई ऐसी इंटरवेंशन नहीं होती मेरे ख्याल से रेस्टिंग ग्रेडियंट लेस देन 30 से ऊपर अब एलवीओटी एक बार सोच ले मेरा ये गड्डी है
25 seconds.
एज है मुझे बताएं एलवीओटी ग्रेडियंट नहीं ठीक है
15 seconds.
It's delta resting gradient less than 30 mm of HE.
D delta. You want me to lock D delta?
Yes, sir.
Okay, lock D delta then. Oh no, that's another mistake. Okay, so you in the other direction. You went in the other direction. The ball was going somewhere else. All right. Still 7 more to go. Buckle up. Can we have the next question? Question number 4.
Which factor has the least direct impact on sudden cardiac death risk stratification in this case according to the guidelines? A is LV apical aneurysm, family history of sudden cardiac death, non-sustained VT, LV gradient of 72 mm mercury provoked, and LVEF of 70%.
All right, 60 seconds. Start the timer, please.
ये है उसमें लिखा हुआ है नॉन सस्टेन VT
Is the silence of the lambs. Come on, Hawks. 25 seconds to go.
Okay. It's LVEF 70%.
E epsilon. You want me to lock E, right?
Yes.
Okay, we'll see whether you're right or not. Lock E epsilon. And it's the right answer. Well done. Well done. Initially, I thought maybe they were not sure, but they went in the right direction and flicked it for a beautiful 6. Well played. Off your toes. Here we go. That's your second correct answer in 4 questions. Almost getting midway with the 5th one. And here it is. Question number 5.
Which subtail CMR feature best explains the predilection for monomorphic VT with HCM with apical aneurysm? Concentric LVH, B is transmural fibrosis in basal posterior wall, C is rim of dense scar at the border of aneurysm, D is epicardial only late gadolinium enhancement, E is uniform septal mid-wall enhancement without thinning.
Your timer starts now.
Fibrosis, origin of that scar. CMR fibrosis explains the prediction of monomorphic. C or D is concentric elevation and transmural fibrosis in the basal posterior. अच्छा rim of dense scar border of ठीक है especially epicardial only.
25 seconds. It's a short pitch delivery. Let's see how they negotiate.
मुझे C enhancement
15 seconds.
क्या करें?
अच्छा fibrosis भी option है.
Fibrosis
10 seconds. Come on. Come on.
क्या
You have to answer. 5. Answer.
It's
Three.
C rim of dense scar.
Okay. Just at the last moment. And I heard C Charlie. So we are going to lock C Charlie. Let's see. And yes, that's a superb answer. Very well done. You got this one right. Oh, just by the skin of your teeth, you got this one. But very well done, Hawks. Great answer. Great answer indeed. So that takes you to a score of 18 now with 3 correct answers, and we are halfway through your innings. 5 more to go. Here comes question number 6.
Which pharmacological adjustment is most appropriate before proceeding to invasive septal reduction or myosin inhibitor in this symptomatic patient? A. Verapamil and star beta blockers. B. Uptitrate metoprolol to 200 mg and add disopyramide. C. Switch to high dose diltiazem monotherapy. D. Is start amidone. E. Add nitrates for angina relief.
And your 60 seconds start now.
Huh?
Start the timer, please.
First line. It's delta start myodrone.
Oh goodness, she's come down the wicket and going over extra cover. Are you sure about it?
Yes.
Which one?
Delta start myodrone.
Okay, he wants me to lock D delta. Ishaq Saab is watching, I know. Lock D delta. Oh, no. We got the wrong one there.
Let me repeat my advice. They should take their time and think about it carefully before answering.
Very right, sir. A lot is at stake. So you must pay attention to what Ishaq Saab is saying. Make the most of it. And you got this one definitely wrong. But you still have 4 more questions to go. Okay. Can we have question number 7 on the screen, please?
In Explorer HCM, which of the following patients would have been ineligible for mevacaptan therapy? A is LVF 70%, LVO gradient 50 millimeter mercury and NYC class 2. B is LVF 62% with non-sustained VT on Holter. C is LVOT gradient 40 millimeter mercury on exercise only. D is LVF 52% at baseline. And E is NYHA 4 symptoms at rest.
And your timer starts now, 60 seconds.
अल्फा यहाँ could have been ineligible for ivermectin therapy. मैसिन कहने से नहीं बेटा ये इसमें
25 seconds.
LP 70% LVT gradient 5G NH2 G काशिफ भाई
15 seconds. Come on, Hawks. 10, 8. Come on.
It's
5.
delta LVEF 52% at baseline.
Okay, you want me to lock D delta. Okay. You're not left with much. We're going to lock D delta. Lock it. Oh, that's another wrong answer. It seems like a flurry of wrong answers. I guess 2 in a row here that we've got. And we are stuck on 18. Okay, you need to push on, guys, because we definitely need to score a reasonable total to have a good fight. And it's a funny game, we know, but still. So you've got 3 more to go. Extremely important to get them right. Best of luck again. Question number 8.
In Velour HCM, which best summarize the primary endpoint? A, change in peak VO2, B, change in LV mass index, C, proportion of patients still meeting criteria for SRT after 16 weeks, D is time to first cardiovascular death, E is incidence of new onset AFib.
Okay, your timer starts now. 60 seconds is what you have.
Change in peak VO, change in LV mass index, proportion of patients still meeting criteria for SRT after 16 week, time to first cardiovascular death, and
So this is the slow bowler, the spinner in action, I guess. It could move either ways. $20 seconds now. 15. Come on.
why not
On your toes. 10 seconds. 6, 5. Come on. 4.
it's beta, change in LV mass index.
Okay, beta. B beta. And again, just at the last moment, the last 2 seconds, I guess they got this one. And they say it's B beta. I'm going to lock B beta and I'll keep my fingers crossed. Lock it. Oh, no. That's another one. Oh, goodness. That's another one missed. So it's a hat trick of incorrect answers now. And Hawks, it's getting tougher. I know. You've got 2 more balls to go, 2 more questions. Be smart about it. And you've got to put up a reasonable total. You can still do that. With this, moving to second last question of your innings. Question number 9 coming your way.
Which safety signal in mevacaptan trials most directly explains RAMS style LVF monitoring in clinical use? A is sudden irreversible cardiomyopathy. B, QTC prolongation of more than 500 milliseconds in 30% of patients. C, reversible reduction of LVF less than 50% in minority of patients. D, high incidence of Torsades point. E is severe conduction block requiring pacing in most cases.
Start the timer, 60 seconds.
Safety signal in ivermectin trials directly explains the style LV. QTC पर ठीक है which signal in ivermectin trials directly explains the style हाँ reversible cardiomyopathy QTC prolongation reversible reduction of
55 seconds to go.
high incidence forces the point is severe conduction block requiring मुझे लग रहा है
15 seconds. Come on, Hawks.
क्या
10 seconds.
Ji, Kashif bhai.
7 now. Come on. Answer.
Beta QTC prolongation. Beta.
Okay, he says B beta. And again, just at the last moment. Okay. And with this lock B beta, let's see. Oh, no, that's another wrong one. This one, 4th in a row. It's a flurry of wrong answers, Hawks. But never mind. It's a grassy pitch altogether. But still, you can still get above 20s, into mid 20s. And that could still be a fighting one for you. So with this, we move to the last question. Question number 10.
In Redwood HCM, epicemptum titration was primarily guided by which combination? A is LVEF and LVOT gradient, B QT interval and troponin, C heart rate and blood pressure, D is BNP and GLS, E is LA diameter and late gadolinium enhancement burden.
Okay, so your timer starts now, 60 seconds. Come on, PIC Hawks. You've got to get this one right.
हाँ क्योंकि ब्लड प्रेशर तो मुझे पता ही है, हर केस में मैंने रिसेंटली एमआरसी में पढ़ा है कि ब्लड प्रेशर अगर है उसके हाई रिस्क फैक्टर्स है ना, उनमें ब्लड प्रेशर है, ये कंफर्म। हार्ट रेट मुझे नहीं पता, लेकिन एलवीएफ एंड एलवीओटी ग्रेडियंट ये भी है वैसे।
25 seconds to go.
LVEF and LVOT gradient, QT interval and troponin है, heart
Approaching 10 seconds now.
NP है, LA diameter
8, 6.
Charlie heart rate and blood pressure.
Okay, you want me to lock C Charlie? How sure are you guys?
Sir, pretty sure.
He's saying pretty sure. Okay, let's lock C Charlie. Oh my goodness, we've gotten this one wrong as well. Oh, 5 in a row this time. Oh my goodness. Okay, so the pitch.
नजर हो गए हमारी टीम नजर हो गई
Ma'am, I think this is now, they've put themselves in a difficult situation, no doubt. It's a low score. And there was a flurry of wrong answers. They kept coming and they kept going. So with this, we now come to the end of this first innings. And we know that PIC Hawks, they've put up a meager total of 18. Only 3 correct answers. And I think they've got their work cut out for them. But let's see, we've seen interesting things in this kind of matches, and you never know what we may have in store for you. And with this, I move to our panel of experts, and we have our umpire, Professor Mohammad Ishaq Saab. Sir, we'll start with you as always.
Yeah, thank you very much. Not very happy this afternoon to see the score. Obviously, I don't think they were well prepared, and it's a very small score. I think the other team should be able to beat it quite easily, but you never know. They may have the same difficulties there as well. So on the whole, a bit disappointed because we have seen much better performance in the previous matches. And today, I think either the question was difficult according to them or they were not prepared. So the other observation that I would like to share with you is whenever there is a female in the group, they come up with the better answers and they have got a better discussion profile. I don't know whether this is correct or not, but that's my observation. So let's see what the other team does and hope for the best. And the losers should concentrate on their mistakes, where they went wrong, and how can they improve their outlook in future. So thank you very much.
Thank you very much, sir, for your extremely important points. And he's, Professor Saab has got such a keen eye, that he at times, he picks things which others may not. And he may have an extremely important point there, but I think still we all at times, we don't try that hard, but then there are times we try hard and it doesn't go our way. We still don't know. We are midway, and we've seen funny things here in this tournament, in other matches, and in life. So I think you still have to give it your best. You still have to fight till the end, and that's what it's all about. We also have Professor Amber Ashraf. I can see ma'am there. Your thoughts, please.
Thank you, Dr. Hamza. Actually, it's always a learning, but the best thing is whenever we come up for any competition, one should have to cover all the topics, all the aspects. That's what I'm observing nowadays in the PGs. They are doing some selective studies. I don't know what is out of course for the exam, FCPS exams and things like this. That is my observation regarding these. But in the previous matches, they did very well. It's a hard luck. And always we learn from these mistakes, and hopefully in the future they are going to improve themselves. But good luck to both the teams. We don't know how the other team is going to play, but from the score, whatever the previous records are, it seems NICVD have a full chances, but good luck to both of them. And what Professor 𝐏.𝐈.𝐂 has always give us a point of a wisdom. And I like this, whenever the girls are there, definitely they start generating, they are more talkative, I think so. And that's why they generate some discussion, and could be they have a better answers. Thank you very much.
Thank you very much, ma'am. Extremely important to highlight these important aspects, I think, of our training, our everyday routines, and how we prepare ourselves. And what we do here is going to be a reflection of what we do in our everyday chores and our performance at work and, everywhere. That's what life is all about. And we keep improving. So still, I think it could still be an interesting game, and we are hoping for that. So with this, we are now going to start the second innings. And I hope the two teams are ready. Hawks,
yes,
you have... Good. So you have to keep your chins up. You have to fight till the last ball is delivered. And we also have Hawks and now the Kings ready for their innings. Let's see how they bat on this interesting wicket with some grass on. Let's see. So can we have case scenario B on the screen? Please go through it.
A 62-year-old woman with non-obstructive HCM presents with progressive exertional dyspnea, orthopnea, and ankle swelling. She has a 10-year history of HCM, no LVOT gradient on prior studies, and long-standing paroxysmal AFib. Currently in sinus rhythm on amiodarone and apixaban. Medications: bisoprolol 75 mg, ramipril 5 mg, furosemide 40 mg, spironolactone 25 mg, amiodarone 200 mg, and apixaban 5 mg BD. Findings: heart rate 68 beats per minute, BP 110/72 mm of Hg, bibasal crackles, pitting edema to mid shin, ECG sinus rhythm, LVH, diffuse T wave invariance. Echo findings: asymmetric septal hypertrophy, maximum of 17 mm, LVA 48%, no LVOT gradient at rest or with Valsalva, restrictive LV filling pattern, severe LA enlargement, mild moderate MR on CMR findings: diffuse mid-wall LGE 20% of LV mass, no apical aneurysm, LV and systolic dimensions mildly increased, CPET peak VO12 ml per kg per minute 38% predicted, LEVCO's slope 38. She is NYHA 3 to 4 despite optimal HFpEF style therapy. The heart failure team is considering advanced heart failure therapies, transplant listing, and whether myosin inhibition has any role in her phenotype.
All right, so I'll give you more than a few seconds to gather yourselves. You can always take a look at the scenarios. So yes, Kings, let me know when you're ready. And I would like to welcome Professor Feroz Memon. I could see there that, I saw a glimpse of him. Welcome, sir. So PIC Hawks, they have put up a score of 18. It's a low score. Let's see how NICVD perform.
Hamza, it's quite a long scenario. Give them a few seconds to read it properly.
Right, sir? Definitely. So do let me know when you have gone through it. Kings. NICVD Kings, that is. All right, Kings, are you ready now?
Yes, we are ready.
Okay, they say we are ready. So with this, we now start the second innings. And can we have question number 1 on the screen, please?
Question number 1. Which description best fits her current HCM phenotype? A. Classic obstructive HCM. B. Non-obstructive HCM with HFpEF. C. Burnt out dilated end-stage HCM. Isolated apical HCM is delta. And E is restrictive cardiomyopathy unrelated to HCM.
All right, you have 60 seconds to answer this in. Let's see what happens now. And I would request the answering team, NICVD Kings, to unmute themselves. We want to hear your discussion. We still can't hear, Kings.
Our mic is on.
Okay, now we can hear you. They're discussing quietly, that's what it is. Approaching 25 seconds. 20 seconds.
We'll go with B beta.
Okay, so you want to go with B beta. You're sure about it?
Yes.
Okay, he says he's sure. Let's see. Lock B beta then. Oh, that one slipped in. Hit the pads. That's LBW on the first one. Goodness. Okay, that's the kind of start PIC Hawks wanted you to have. Okay, that's an interesting start. Okay. With this we move to the next question, and I'll request everyone else to keep themselves on mutes because it becomes difficult to hear everyone. So keep yourself muted, please. Only the answering team should have themselves unmuted. Okay. Can we have question number 2? Read it,
question
please.
number 2. Which variable most strongly supports evaluation for heart transplant according to guidelines principles? A. Age 62. B. Peak VO12 ml per kg per minute. C. Mild moderate MR. D. Paroxysmal AFib. And E. LVEF 48%.
All right, you have 60 seconds to answer this in.
Burnout हो गया. Heart transplant according to
Approaching 25 seconds.
We'll go with B beta.
B beta. You want me to lock it?
Yes.
Okay, so we are going to lock B beta. Oh, yes, that's the correct answer. And just like PIC Hawks, you get this second one correct. And it's the correct answer. Nicely played, 6. And we're on the board now. Good one. Okay. So with this, we're now going to move to question number 3.
Question number 3. Which single finding most clearly distinguishes her phenotype from HFpEF due to hypertensive heart disease? A. Septal thickness 17 mm. B. Severe LA enlargement. E. LVEF 48%. D. Diffuse mid-wall LGE 20%. LV mass. E. Age more than 60 years. Delta.
Okay. Start the timer. It's a short pitched one. Let's see whether they pull it or cut it.
septum now.
25 seconds to go.
Diffuse.
Come on, Kings.
Which single family is Now
10 seconds.
We'll go with a septal thickness more than 17 mm.
Okay, you want to go with A alpha.
Yes.
First A, I think, of today's match. So let's lock A alpha and see what happens. Oh no, this is the wrong A. Wrong answer. My goodness. I told you it could be a funny game. So both the teams going neck and neck seems like, with a score of 6. NICVD still have to get at least 3 answers correctly to get into the semis. Okay? But you have 7 more questions to go. We have question number 4 coming your way.
Question number 4. Regarding ICD therapy, which statement is most accurate for this patient? A. ICD is contraindicated because of EF is not less than 35%. B. ICD is clearly indicated due to extensive LG and LVF less than 50%. C. ICD is never useful in non-obstructive HCM. D. ICD is only indicated if she develops an non-sustained VT or syncope. E. ICD is unnecessary if transplant is being considered.
Your 60 seconds start now. Approaching 25 seconds. There's a very calm and polite discussion going on at the NICVD Kings HUD. 15 seconds to go. Come on.
D. We'll choose D delta.
D delta. Are you sure? I should lock it?
Yes.
Okay, they want me to lock D delta. Lock it, please. Oh, no, that is the wrong answer. Okay, that's another wrong answer. And I hope you're not getting towards another hat trick coming from you this time of wrong answers. Okay, so you need to get moving. With this, we now move to question number 5.
Question number 5. Which immediate pharmacologic adjustment is most reasonable? A. Stop ACE inhibitor. B. Add higher dose nitrates. C. Consider adding SGLT2 inhibitors, example dapagliflozin. D. Stop beta blockers. E. Start diazepam.
And your timer starts now, 60 seconds.
SGLT को नहीं देंगे 48% ये बीटा प्लस दूसरा क्योंकि नॉन सस्टेन बीटी वाला है एक वो
25 seconds to go.
नहीं उन्होंने पहले बीटा ब्लॉकर और वो वाले उस वजह से दे रहे हैं
15 seconds. The ball is moving. We know. 7,
कह रहे हैं
6. Come on.
we'll
Answer.
go with C Charlie.
Okay. Just in the nick of time, you say C Charlie. And I'm going to lock C Charlie. Fingers crossed. And yes, you got this one right. Good answer. Very well done. They were really thinking hard and deep. The team was together, and then they came up with the right answer. Much needed one. So there is no hat trick of wrong answers. They were able to save themselves. Well done. Good answer there. So we've still got
Dr.
5
Hamza?
more to go.
Dr. Hamza, please
Yes, ma'am.
ask your technical team when they are showing the answers, they make that screen visible. We love to see you, but we want to see that questions, which one is right and wrong, because it's our learning.
You can't see
as
that,
well.
ma'am?
No,
you can't see
I'm
that?
just observing and seeing your beautiful facial expressions and wonderful
okay. I
commentary.
think we definitely
you.
need the screen
Thank you.
on. The technical team, I think you must take notice of that.
Your
And do they have to?
your glowing cheeks and bright face, but yes, I think I agree with Amber. We don't see the result. You
So
see,
that glow is actually the radiation coming out after doing 30 hours in the cath lab. So I think it's mostly because of
No
that.
doubt.
Never.
No doubt of the procedures.
People spend a lot of money to get this glow.
I think the
sir,
cath is
another
doing
thing,
it for me. Alhamdulillah.
I want to add, whenever in the cath the response and results are good and you do a difficult cases, definitely this glow outshines, mashallah.
Thank you very much, ma'am. We just had 20 plus primaries overnight. So, so that's, I think that's where the glow is coming from. But I think they're going to put this right because they definitely need to see this. Hamza, do they have to pin the screen or something like that?
Yes, sir, they have to pin.
Okay, ma'am. And sir, I think you'll have to pin the right screen from your gadgets. And once you pin that, that becomes your main screen. So I hope you've done that. If you haven't, because I think you probably have pinned my screen. So if you
No, Dr. Hamza, like we have marked the right screen. Actually,
Okay.
previously what happened, whenever there is an answer, they show us that 5 options, whether it is red or green. Now we are just having your
Okay.
nice face.
Okay, I think it's a technical challenge for them. I think there's a new person handling it, and they're coming around it. So I think Hamza and his team will be on it. I think you must,
Hamza,
put this
carry
right,
on.
Hamza.
Go ahead. Carry on. That was the one observation. That's why I've shared with you. Thank you.
Right. Thank you very much, ma'am. So we're going to move on. It's getting interesting. We still, we've got 5 more questions, and they are getting close to it. They've scored 12 already, 1 more to equal, and 2 more for victory, and getting into the next stage. So let's bring question number 6 on the screen.
Question number 6. Which factor most predicts poor transplant-free survival? A. Paroxysmal AFib, B. LVEF 48%, C. Peak VO 12 ml per kg per minute and VE over VCO 38, D. Mild to moderate MR, E. septal thickness 17 mm.
All right. You have 60 seconds. So we can't hear the discussion. I think they're doing it quietly. I hope they're not muted.
जो पहला क्वेश्चन था कि जो हमने एक तो हाँ नहीं प्रिजर्व तो है ना
25 seconds. Could this be the mystery delivery now? I think the slow bowler is in.
जो पहले मुझे नहीं लग रहा हाँ
12 seconds now. Come on. Hurry up.
We'll choose C, Charlie.
Okay, C, Charlie. And you look confident, don't you?
Yes, yes.
Okay, he says yes, yes. Lock C, Charlie. And yes, boy, is he confident. Well done. That's the right answer. A good answer indeed. So that actually takes us to 18, and we've got 18 apiece. Scores are level. And you have 4 more questions to go, and you just need one correct answer to get into the semis of this third season of Pakistan Cardiac Super League. And with this, we bring question number 7 on the screen.
Sir, before question number 7, are there chances of rain?
I think that's all you can hope for, because if they get 4 incorrect answers, then boy, God help me, because
Okay,
I've got
sir.
another super over
Okay.
then.
Thank you, sir. Question number 7. Which statement best reflects the relevance of Maverick HCM to this patient? A, if enrolled end-stage HCM with EF less than 35%. B, it showed definitive mortality reduction with mavacamten. C, it studied non-obstructive preserved ejection fraction HCM with elevated biomarkers, not frankly reduced EF. D, if provoked myosin inhibitors reverses fibrosis. E, it demonstrated cure of AFib.
All right, start the timer, 60 seconds. And I do believe rain won't do for you. You need a tsunami.
Yes, sir.
नहीं ये तो नहीं होगा. C आंटी, C मुझे लगा. Myosin improved myosin inhibition reverses type.
Are they going to sweep this one for a 6? They're eyeing the square leg boundary, I see. 20 seconds to go.
B, C मुझे लग रहा है C. Non-obstructive.
12 seconds. 9.
क्या करें?
6 seconds. Come on now. 5.
Go with
4.
delta. D, delta.
Okay, they say D delta. And we're going to lock D delta. And let's see what happens. Lock it. Oh, that's the wrong answer. Somebody was saying C. Somebody was saying C. And then suddenly we get D delta. Okay, team. A lot of discussion going on.
हमजा ये लोग दुआएं कर रहे हैं बारिश हो जाए.
फिर पूरे लाहौर की चाहिए होंगी इनको.
We are not ready for super over.
It would be a disaster if we get into a super over from here. But, you never know. You never know. We would love to have it. Okay. So we've got 3 more to go. You just need one right answer. Odds are very much in favor of NICVD Kings. But then again, we don't know. We know nothing. And we've seen nothing. So question number 8. On your screen now.
Question number 8. Based on current evidence, which best describes the role of myosin inhibitors in HCM patients with ejection fraction less than 50% and no LVOT gradient? A, class 1 indication for symptom relief. B, class 2A indication to prevent transplant. C, considered harmful and generally not recommended. D, proven to improve survival. E, recommended only in pregnancy.
All right, 60 seconds coming your way. So can't hear Kings. Come on, Kings, we can't hear you. We want your discussion.
नहीं.
25 seconds to go.
होंगे ना. HCM 50% कम होंगे.
15 seconds.
तो कौन सा select करना है?
9, 7,
जल्दी बता.
4. Come on.
C.
Answer.
C, Charlie.
Oh, just at the last moment, they say C. Okay, this time they are saying C, and we are going to lock C, Charlie. Let's see what happens. And it was the correct answer with this. Wonderful answer. Kings, you've done it. And we now know who's getting into the semis. Great job. Well played. Very well done indeed. And I see, I've never seen the other team getting so much excited. PIC Hawks, what's going on? You're so excited.
Great.
Sir, there was chances of drizzling and it started but suddenly stopped.
You were really hoping for that. We all know. But I told you it would take a tsunami from here on. But I think very well done. Very well done.
Great.
Great, mashallah. And I think we still have 2 more questions to go. And in the interest of time and also for knowledge's sake, we have to know. And then I think this may just matter if we have a stutter somewhere in the tournament. So more marks, more points will always benefit any team. Second last question of the day now we know is coming your way now.
Question number 9. Trials of valsartan in early HCM vanish would apply how to this patient? A, directly applicable as she is early gene positive HCM. B, not directly applicable, she is advanced end stage HCM. C, provides strong evidence to uptitrate valsartan for gradient reduction. D, show that valsartan reverses established fibrosis. E, indicate valsartan can be stopped in advanced heart failure.
All right. 60 seconds.
She is deployed of end stage. She is early gene. We'll go with C, Charlie.
Okay, now they're stepping down on everything and trying to smash everything out of the park. Now they know that they've won. We can see them discussing it, chirping like anything. Okay, you want me to lock C?
Yes.
Okay, lock C, Charlie. Oh, you missed this one. Okay. So that's the wrong answer, but never mind. It's not going to affect the outcome of this game, at least. And with this, we move to question number 10.
Question number 10. What is the main extrapolated lesson from SGLT2 inhibitor trials DEPA HF Empress reduced for patients like her? A, SGLT2 are contraindicated in HCM. B, SGLT2 inhibitors should only be used if ejection fraction more than 60%. SGLT2 inhibitors can be considered to improve heart failure outcomes even without diabetes. D, SGLT2 inhibitors reverse LGE in HCM. E, SGLT2 inhibitors eliminate atrial fibrillation recurrence.
Okay, your 60 seconds start now. That's the last question of the match and the day. Let's see what happens.
We'll go with C, Charlie.
Okay, they've come down the wicket, trying to lift it from the pitch and going for a straight drive. So you want C, Charlie again?
Yes.
You're really fond of C, Charlie. Okay, I'm going to lock C, Charlie, lock it. And this is the correct answer. Well done. This time C, Charlie worked for you and wonderfully done. Very well played. And we now, exactly, ma'am. It's definitely a wonderful performance. It was a difficult pitch to bat on. We knew that. Green top, as we always, we are wary of that, and we dread a green top. It shows difficulty. But they played well. They came up with the right answers. And I think it's a good total to have, at least on this kind of a pitch. A score of 30 in the end, whereas PIC Hawks scored 18. So very well done indeed. And we now know the outcome. It is NICVD Kings who have advanced into the semi-finals. So well done. Very well played. Commiserations to PIC Hawks. But never mind. You'll do much better in your coming days, in coming competitions, and in your respective lives, because we know that you're all brilliant.
Thank
All
you,
right.
sir.
You're most welcome. And moving to the panel of experts, it's always Ishaq Saab who's there as the umpire and as a guiding star. Sir, your thoughts, please.
Thank you very much. Very exciting fight by I'll call them NICVD kings and queens, because there were some queens sitting as well there, you see. Sara
The lucky charm.
So I think they played very well. एक तो स्कोर बहुत बड़ा नहीं था इनके लिए, तो अगर ये हार जाते तो बहुत बुरी बात होती, क्योंकि स्कोर was not very high. But I think they played well, carefully, and obviously they won the match. Congratulations to them. And as you have tried to console the losing team, they should keep up with their efforts, improve their knowledge, and do not go disheartened from here. But obviously their score was much less than what we expected of them, you see. So I think that's a game. One has to lose, one has to gain. And the loser should concentrate and focus on their studies and improving their knowledge by reading into the latest developments on Google and Medscape and all sorts of things. So I think very interesting match, and we are going towards semi now. And thank you for your excellent moderation. Thanks to Hamza and to Madam. She's always there. I appreciate her presence and nice comments. We enjoy this match, and I think we should just carry on what we are doing. So thank you very much.
Thank you very much, sir, for your comments as always. He's always to the point, and some great points and great pearls of wisdom from Professor Muhammad Ishaq Saab, and he's always there for us. That's the best part. So with this, I now move to Professor Feroz Memon. He's there. We would like to hear from him also. Sir, are you there? Okay, ma'am, I think Professor Amber Ashraf, she's been there all along. Ma'am, are you there?
Thank you, Dr. Hamza. It's a wonderful inning. And really, I think so. NICVD did nicely, and somebody was sitting and praying for them, same as the cricket match of Pakistan and India, right? But I'm not saying the other team is India, but I'm just recalling the way we are praying. Allah Ta'ala kuch mojza dikha de ke hum jeet jaye. The NICVD, initially when they started, they go one by one as the PIC was doing. But mashallah, that is something great in the sense that they scored a nice number. Otherwise, PIC कहता कि हम बराबर बराबर थे और बस एक बॉल से जो है जीत गए. But whatever I want to highlight here to our youngsters, that's very important to go through their academic content, because cardiology is not only wires and catheters. As Dr. Hamza, you as a hero, and you say I did 20 primary in the night, definitely everybody become fascinated and they want to be a hero like all of you. But what my message is, no doubt intervention is the need of the day and the time, but the basic foundation is our basic cardiology knowledge, because we have to manage our patient even before cath, during the procedures, and later on. That's what I'm telling to my PGs day in and out. Please do go and study these guidelines, understand the basic crux which are important for implementation in patient management. And both the scenarios, what I anticipated were a practical application of the knowledge, and that's why that is the thing. So great, wonderful, congratulations to both the teams. At least the PIC reached here from so many competitions. That's wonderful. Thank you, Professor Ishaq Saab, कि आपने बोला कि females की वजह से टीम जीतती है. So that's why I'm very happy on that. 50%, queens and kings. And thank you, Wilson, Hamza, and your moderation always put a jaan into it. Thank you very much. मैंने अभी प्रोसीजर शुरू करने थे. अच्छा है कि ये टेंशन खत्म हो गई है. अब मैं पीस ऑफ माइंड के साथ जाके करूंगी. थैंक यू वेरी मच. Great.
Thank you very much, ma'am. And, you've explained it so nicely as always. And, it's so good to have you here with us. You take the spirit to the next level for all of us. And best of luck with your cases. Inshallah, you'll do amazing over there. You're such a stalwart for everyone there in your part, and in fact, in the whole of Pakistan and all around, and also for the women and the women power that we talk about. So that's role modeling for all of you. This is how you do things, mashallah. And with this, I think I do see Professor Feroz Maiman. Sir, can we have a few words with you? Are you there? So I think Feroz Saab is probably not there. It would have been great to have him over and say a few words, but I would just now in the end move to the two teams. So, PIC Hawks, your thoughts. Just a few words. How do you feel? How was the match?
So match was interesting. First of all, congratulations to the NICVD Kings, and inshallah next time we will come up with a great spirit and the well preparation. Inshallah, it was a good match and a good opportunity for us to appear in such competitions, and these competitions are definitely improve our knowledge and give us motivation to study more and learn about latest guidelines. Thank you very much, sir, for arranging such competitions.
Thank you, Hawks. It's a pleasure having you, and you are such amazing people. I think in your training programs, you're doing wonders over there. We know how brilliant your institute is, and winning and losing is just something that happens on everyday basis. It's the stuff that you learn as you go along. So I think all of you will do wonders, inshallah. And
yes, sir,
we do have inshallah, the winning team for today's match, NICVD Kings, who have advanced into the semis. Your thoughts, please.
Assalamu alaikum. Congratulations to my teammates and good luck to PIC Hawks. And I also want to congratulate my friend does residency there in PIC. And of course, it's India versus Pakistan between us, but of course, goodwill. So it was a good competition. And inshallah, we'll try.
Sir, we never considered it like Pakistan or India. We just considered it like the fellows.
I said in a goodwill.
Okay, thank you.
Okay, so that's the spirit. You see, when we say India Pakistan, it's not the that other aspect. It's the camaraderie and the level of competition that we are looking at. So, and this is good to see. When you're competing, you have to compete. Even the best of friends compete, and that's so good to see here. I think best of luck to both the teams. It was wonderfully done. And with this, we come to the end of this match, the fourth and the last quarterfinal. And we know that NICVD Kings have advanced into the semifinals, and it's going to be another wonderful series of semis, as we have seen one, and then we'll have the finals. So we are all gearing up for that. But till that time, it's Allah Hafiz from my end. Till I see you next time, and be prepared for that. Allah Hafiz.
Thank you very much.
Take care.
Thank you. Thank you.
Thank you. Thank you very much.